larger than the cannula that's going in. So we want the contrast to get out fast as well. So this is why we'd like to do that. Samuel Underhill, another question. How important is bolus length, going back to my formula? Well, you know, I don't look at the formula in gastrointestinal imaging except in renal, and we'll talk about that next week. But when we talk about CTA, we'll be using a formula when we look at the bolus length. But one thing to remember is this. In contrast media delivery of the liver or any other structure that we're looking at, we want to get the contrast to the right place at the right time so we can image it at the fastest possible rate with the least amount of artifacts. And by doing this, this is important. This is what the whole system is about. We have another question from Kalindi Dalal. What should be the ratio of contrast and saline for best imaging? So usually I always give, you know, the 100 mils, or depending on body weight protocol that you use, because people do different volumetric strategies as their own. And then I always have 100 mil saline to push every single time. This is the way that I actually do it. But more importantly, it's not just about, you know, the volume of contrast. It's about the actual components or the characteristics of contrast. This is why manufacturer's job is to tell you the truth. And this is why I'm grateful that Bayer allows me to speak the truth in this stuff. Lydia Sneyman, on a 16-slice CT scanner, we only have a single barrel injector and no saline chaser. What can be good to get done? What can be done to get good enhancement in large patients? Well, first of all, thank you for that question. I'm not Superman here, but you know, you'd have to use larger volumes of contrast. You would have to use saline, but then you'd have to fill in saline and then contrast, and then tip your syringe down, and you're going to have to wait at least 5 minutes for the contrast and saline to separate, and you have to inject that entire volume. This is the only way I could really answer you on this question. But excellent question. But you know, a double barrel, ladies and gentlemen, is preferable, and because this is what all of this is based on. Nina from Lebanon, do you shape the enhancement of lesions change in CT after chemotherapy? So exactly. So with chemotherapy, now, ladies and gentlemen, this is a fantastic question, because patients who've had chemotherapy or radiation therapy, they've been vomiting the whole time, they're feeling sick, they're not eating, they can't keep food or fluids down. So their actual hydration status is very, very low. So that means we need to have contrast to push it through there as well. We'll probably take maybe questions are flowing in. So Leona, we'll probably take a few more questions if that's okay by you. Did you want me to keep going?
Yeah, I think, Charbel, it's completely up to you as well, because you've been working very hard now. I think we had 2 hours total, so we've still probably got, yeah, let's take another 10 minutes, but up to you, Charbel, because maybe you're starting to feel tired.
No, I'm fine. I've got my cup that I got from a great gift from Taiwan. I just have a glass of water first, just so my voice can keep up with it. So we have another question from Rasha Itani. Should the flow be altered in the case of large patients in the way that it doesn't damage the cannula? Amazing question. Remember, you know, the flow should not be altered with larger patients in liver imaging, because when the large patient puts his arm up above the head, we actually compress the brachycephalic vein. So we've reduced the flow of contrast coming in. The question here is, how do we place our arm relatively to that? Okay, so we can allow the contrast to come through. Adrian Bickow, how should the protocol adjust depending on the number of detector rows? Well, let me tell you something. You know, the number of detectors in CT only determines how fast or how slow we're scanning that patient. But remember this, contrast media is we get the contrast in the right place at the right time. And this is what is more important. So excellent question, Adrian Bickow. Thank you so much. Dennis Wu, when is the best time to start the scan visually with the bolus tracking in relation to a TACE patient or hemochromatosis patient? Oh, fantastic. So hemochromatosis, patients who have actually increased iron overload within the liver, and patients who have had actual TACE, okay, they've actually, which they've put in little spheres into the hepatocellular carcinoma lesion. And this is where I got actually the 8 seconds from. So I don't visually look at the enhancement. I actually wait until I reach 180 Hounsfield units at the bolus track, and my 8-second interscan delay actually accounts for that. So this is the beauty of this. Now, if you're fantastic, that is an excellent question. Wow, we've managed to answer 139 questions. Ladies and gentlemen, I'm impressed. Thank you so much. Do we have any more questions? We're up to date with our questions.
Maybe you did it, Charbel.
Is this the world's first lecture series online that we've had all their questions answered? Is there anybody that I didn't answer their question? Because I was also typing while Leona was talking, and so yeah. Actually, I've got one question that I didn't answer. Nihad, how do you give contrast directly to the liver? Well, if you're doing interventional radiological procedures, you can do this through the hepatic artery or through the portal vein system. Now, this can only be done if a patient has hepatocellular carcinoma. I've got questions on renal delay time. We'll be talking about renal next week. I have another question. Does this method pose a challenge when imaging the elderly? Exactly. So let's think about this. A patient has been up in the ward or in the hospital bed for a week, and this patient has in actual fact dehydrated. The air conditioning dehydrates the patient. Definitely it affects it. That's why hydration and saline is important. We've had a few more come in. What can be a protocol in patients whose upper limb IV could not be opened? I mean, lower limb approach. Fantastic. So if you're going to do a lower limb approach, it's actually even better. You actually get better enhancement because in the upper limb, you're only injecting contrast. So 30% of the blood coming from the head and neck goes to the right atrium. So half of that, 15% is going to be, or 50% of it will be diluted of that 30%. Whereas if you're injecting from the lower limb, okay, you're actually getting, it's 70% of blood coming into the heart. So 50% of that is actually 35% density. So in actual fact, you end up getting 2.5 more times more injection in density. So I have a question from Pataporn Susawakat. I know that name very well. That's from Thailand. Any tips and tricks for pediatric patients in liver imaging? Definitely. If you just use the same thing that I told you, by using contrast and saline, and use 1 ml per kilo for contrast volume measurement and 1 ml per kilo for saline, and using 370 density, it is approved to be used on pediatrics under the ages of 2. You get perfect imaging. But remember, when you have patients that have neuroblastoma, you need to wait 90 seconds for a venous phase. Now, I have another question from Ashish Verma. Is from India, thank you. Is there a way to calculate the rate and KVP of NASH? We have many patients and lots of variability enhancement. So KVP, I always like to use 100 KVP. And also with the flow rate, I always like to use 4.5 mils a second. But use the 100 mil saline at 4.5 mil to keep pushing it through. Okay. Justin Kids, how do we reduce the effect of intestinal peristalsis artifacts on other organs? We will talk about that in 4 lectures time when we talk about gastrointestinal tumors. I will give you a technique of how it works. Now, Kalandi Dalal, if the creatinine level is more in a patient, what will affect and which contrast do we use? Let me tell you something. Creatinine, we don't look at creatinine anymore for contrast media delivery. We look at the EGFR, the estimated glomerular filtration rate. And what happens there is, what we do is we actually, if it's below 6, it's between, below 30, no contrast media should be given at all to the patient. If it's between 30 and 50, patient goes and has hydration therapy, and anything above 60, patient has it. This is the way to do it, and this is the only way to do it. Otherwise, you're putting the patients at potential risk. Gokran, how about venous study of the lower limb protocol? We'll talk about that in the vascular CTA series. Adrian, from your experience, when is the right time for biopsy? So for a liver biopsy, okay, whenever you see a lesion, anything that's greater than 3 millimeters, and depending and the delay time, that's when radiologists and surgeons will then definitely provide a suggestion for biopsy. So now we're at 150 questions that we've answered. Excellent. Any other questions, ladies and gentlemen? Excellent. So I just want to once again say thank you so much to Bayer Asia Pacific and Bayer Worldwide, because we've had people all over the world log in. I'd like to say thank you to all our amazing radiographers, radiologists, medical people that have logged in to see this lecture. You all inspire me to keep doing my work and find more answers and truth. And whatever you've learned today, I'm grateful, because I've also learned a lot from you, from your questions. And a big thank you to you all. Thank you so much, and have an amazing evening, morning, or day.
Well, thank you, Charbel. And here's Yewon to tell us about what's coming up.
Yes, thank you, Dr. Charbel, for your valuable and wonderful lecture today. And thank you all participants for joining the CT protocol optimization webinar today. We really appreciate for your attendance and active participation, as it was shown by the number of the questions that Dr. Charbel received. And actually, before I announce for the next lecture that's coming tomorrow, on the bottom of the screen, there is a green box with a chart icon that you can click on. And this leads to the 4 short survey questions. And we'd really appreciate if you can give us feedback on today's webinar.